The role of the nurse in the insertion of peritoneal dialysis catheter. In this video, I will discuss the role of the nurse in the insertion of peritoneal dialysis catheter, the type of material that the catheter is made from, advantages and disadvantages, the pre-insertion preparation of the patient, pre- and post-operative care, and the long-term care of the exit site. There are different types of peritoneal dialysis like CAPD, IPD, CCPD, and TPD. I am choosing CAPD, which stands for Continuous Ambulatory Peritoneal Dialysis. CAPD are suited for patients with average or low peritoneal membrane permeability. It is also for patients who want home-based therapy and who wish to travel. CAPD does not use a machine because you do the exchanges during the day by hand in any clean, well-lit place. Each exchanges takes about 30 to 40 minutes, and during an exchange, the patient can talk, read, and watch television. With CAPD, the solution stays in your belly for 4 to 6 hours. It's called dwell time. Usually, you change the solution at least 4 times a day and sleep with it in your belly at night. The patient in this modality is independent and can perform dialysis without the help from medical staff. What are the advantages of CAPD? So as I already mentioned, one of the advantages is uninterrupted sleep because you do not have to wake up at night. It improves patient employment opportunities, good control of blood pressure, marked improvement of anemia, and unrestricted diet. The disadvantages are risk of peritonitis, hypoproteinuria, and hypertriglyceridemia, surgical or mechanical catheter related, treatment failures such as dialysate leaks, hernias, interstitial obstruction, encapsulating sclerosing peritonitis. PD catheters come in different lengths, shapes like straight, pigtail, curled, and swan neck, and the number of Dacron cuffs. The Dacron cuffs are for optimal ingrowth and fixation. In this video, I will use a swan neck pre-sternal catheter. So when you have a kidney failure and will undergo peritoneal dialysis, you may wonder if you can prefer a bath or a shower. If you are obese or have an ostomy, you may also wonder if this will work for you. Well, pre-sternal catheter may make peritoneal dialysis work for you, and that is the reason why my patient is choosing this type of catheter. Swan neck pre-sternal catheter is composed of 2 silicone rubber tubes which are cut to an appropriate length and connected end to end at the time of implantation. The great flexibility permitted by cutting the upper portion to length in the operating room means that the catheter exit site can actually be tailored to come out anywhere on the upper abdomen or lower chest as the patient and surgeon determine to be the best. A catheter exit site on the chest has the advantage of minimal wall movement, decreasing chances of trauma and contamination due to the piston-like movement of the superficial cuff in the abdominal wall. The great flexibility permitted by cutting the upper portion to land in the operating room means that the catheter exit site can actually be tailored to come out anywhere on the upper abdomen or lower chest as the patient and surgeon determine to be the best. And what are the advantages of pre-sternal swan neck catheter? As I mentioned, it has a decreased risk of exit site infection, decreased risk of peritonitis, decreased risk of intraperitoneal tip migration, decreased risk of pericatheter leaks, and better psychological acceptance of the catheter. More than 20 years after the introduction of pre-sternal catheters, they tend to perform better as compared to the abdominal catheters with respect to removal due to exit and tunnel infections, peritonitis, and overall survival. Patients with ostomies and obesity also do better with the chest catheters as compared to the abdominal catheters. Patient acceptance of the pre-sternal exit site is also good due to psychological and body image reasons. A chest exit location allows a tub bath without the risk of contamination. Pre-sternal catheters are also very advantageous with small children because of the greater distance from diapers and are subjected to lesser trauma during crawling and with falls. Disadvantages of the peristernal catheter are minimal. Compared with abdominal catheters, dialysis solution flow is slightly slower because of the increased catheter's length. However, slower flow is insignificant clinically. There is a possibility of catheter disconnection in the tunnel, but this complication is extremely rare in adults and easily corrected. Finally, the implantation technique is more challenging compared with that of single-piece abdominal catheters. So now we're going to discuss about the pre-insertion care. PD catheters should be placed 2 weeks before starting peritoneal dialysis to allow tissue ingrowth and prevent leaks. If dialysis has to start before the 2 weeks healing period, the patient must be in a supine position with small fill volumes. Nurse's role would be to assess the patient for hernias, and plans should be in place for repair during PD catheter insertion. Exit sites should be accessible to patients for exit site care. Have the patient shower on the morning of insertion using chlorhexidine. Bowel preparation to avoid distended bowel that could interfere with placement and function post-insertion. Advise patients to empty the bladder. Insert Foley catheter in patients with neurogenic bladder. Number 6, prophylactic antibiotics prior to peritoneal dialysis catheter insertion, usually an hour prior. Monitor laboratory values in holding blood thinners prior to procedure as per hospital policy. Post-operative care of the patient. Catheters should be immobilized at all times to prevent trauma. Avoid activities that will increase intra-abdominal pressure like coughing, straining with stool, bending over, squatting, or stair climbing. Leave the exit site for 7 to 10 days after insertion of the catheter. Exit site dressing remains 7 to 10 days to minimize bacteria colonization during the healing period. PD catheter must be flushed with 500 to 1,500 ml of peritoneal dialysis fluid solution to check for patency. PD should be started until healing at exit site and tissue ingrowth into the catheter's deferent cuffs have taken place, usually after 10 days. If peritoneal dialysis is required prior to the 2 weeks healing period, you can do this by low volumes and in supine position to prevent leakage. What are the long-term care of exit site? Long-term care of exit site begins when exit site is healed, usually 2 to 3 weeks post-implantation. A healed exit site has no gapping, erythema, drainage, crusting, or tenderness. So number 1, exit site should be cleaned if it becomes wet or dirty. Most clinics recommend daily care. Hand washing should be done before touching the catheter. The site may be cleaned with liquid antibacterial soap or an antiseptic that is non-cytotoxic. Harsh solutions should be avoided as they can cause skin damage that predispose to bacterial infections. To prevent contamination, soaps and antiseptic should not be transferred from one container to another. Vinegar can be used for exit site cleansing in conditions when water is contaminated or unavailable. Always secure PD catheter to promote immobilization, reduce risk of trauma and infection. Swimming and bathing can still be considered as long as waterproof or occlusive dressing is applied. Patients are discouraged to immerse exit site in water without waterproof dressing, hot tubs, or activities such as diving because it creates tension on the catheter. So my patient is satisfied with the continuous ambulatory peritoneal dialysis because it encourages self-care and independence and frees him from hospital-based treatment. On top of that, he can travel if he wants to, and with the Swannick peristernal catheter, he can continue to enjoy his bath. Quality of life is good because he has a better psychological acceptance of the exit site. Thank you.